Good morning, Madam Hidayah. Today, I would like to present my occupational therapy case study for my client, whom I will refer to as Mr. K for confidentiality. Mr. K is a 74 years old Chinese gentleman who was admitted from 19th February 2026 until 4th March 2026. He was admitted due to deconditioning following an acute right cerebellar ischemic stroke, which was his third episode of stroke. The main focus of my occupational therapy assessment and intervention was to identify his current occupational performance, problems, and provide appropriate intervention to improve his independence, safety, and participation in daily activities. For personnel, firstly, in terms of his personal background, Mr. K is a 74 years old geriatric gentleman. Throughout the assessment and intervention sessions, Mr. K was cooperative and highly motivated to participate. He consistently attempted to perform activities independently whenever possible, even when he experienced physical limitations. No refusal, agitation, or inappropriate behavior was observed throughout the assessment and intervention sessions. Mr. K also demonstrated a strong desire to regain his independence in his daily activities, which is considered a positive factor for his rehabilitation. So in terms of family support, Mr. K lives together with his wife, who is his primary caregiver. His wife provides assistance and supervision during daily activities, particularly during dressing and functional mobility. She assists him when required, while also allowing him to attempt activities independently. Mr. K has 2 children. His eldest child is working in Singapore, while his younger child is currently a student. Overall, Mr. K has good family support, particularly from his wife, who is actively involved in his rehabilitation and daily care. Education. In terms of education, Mr. K completed his formal education up to standard 6. His educational background is important to consider during occupational therapy intervention because complex or lengthy instruction may be difficult for him to understand, particularly together with his existing communication and comprehension difficulties. Therefore, during therapy, I used short, simple and clear instruction, gave one instruction at a time, and demonstrated the task before asking him to perform it. Medically, Mr. K has a history of hypertension and dyslipidemia. His hypertension is currently managed with medication obtained through the My Ubat application form KKSI. He also has a history of recurrent cerebrovascular accidents with aspirin failure. His first ischemic stroke is in 2015, and his second ischemic stroke occurred in 2023 and resulted in expressive dysphagia. In 2026, he experienced his third stroke, which was diagnosed as an acute right cerebellar ischemic stroke. Disability status. In terms of his current disability status, Mr. K presents with slurred speech, impaired balance, slight tremor, and an unsteady gait which affect his functional mobility. Socially, Mr. K demonstrates a positive attitude towards rehabilitation. He is highly motivated to regain his independence and actively participates in therapy. In terms of his environment, Mr. K lives with his wife, who provides supervision and assistance when required. And then, based on the information gathered from the assessment, I identified 4 main occupational performance problems using the occupational therapy practice framework. The first problem is that Mr. K is unable to perform dressing independently. This is evidenced by his MBI dressing score of 5 out of 10. His dressing difficulty is related to impaired balance and reduced bilateral upper limb strength, which are supported by his Tenaty score of 11 out of 28, and bilateral grip strength below the stated normative values. His wife also reported that he requires assistance during the initial stage of dressing. According to the OTPF, the affected occupation is activities of daily living, specifically dressing. The affected performance skills are mainly motor skills such as stabilizers, reaches, bends, coordinates, and manipulates. The affected client factors are neuromusculoskeletal and movement-related functions, particularly muscle power and balance functions. The second problem is impaired functional ambulation. Mr. K's MBI ambulation score was 3 out of 10, indicating that he requires substantial assistance during mobility. This is related to impaired balance and abnormal gait performance, as supported by his TINETI score of 11 out of 28, indicating a high risk of falls. According to the OTPF, the affected occupation is activities of daily living, specifically functional mobility. The affected performance skills include walking, stabilizing, coordinating, and moving, while the main client factors are balance and gait-related neuromusculoskeletal functions. Problem number 3. The third problem is reduced bilateral grip strength affecting functional hand activities. Mr. K demonstrated reduced grip strength in both hands, with the right hand measuring 14.7 kilograms force and the left hand measuring 20 kilogram force, both below the stated normative values. This may affect his ability to grasp, hold, and manipulate objects during self-care activities, particularly dressing and other activities that require functional hand use. According to the OTPF, the affected occupations include ADLs such as dressing, feeding, and grooming. The affected performance skills are gripping, manipulating, coordinating, while the main client factor is neuromusculoskeletal and movement-related function, particularly muscle power. Problem number 4. The fourth problem is an increased risk of falls during functional activities. Mr. K obtained a TINETI score of 11 out of 28, indicating a high risk of falls. He demonstrated hesitant and discontinuous gait, frequent stopping during turning, marked trunk sway, and reduced gait stability. According to the OTPF, the affected occupations include functional mobility and community mobility. The affected performance skills include walking, stabilizing, positioning, and moving, while the affected client factors include balance and postural control. Based on the 4 identified problems, I developed 4 relevant treatment aims. Aim 1, dressing. The first aim is to improve Mr. K's independence in dressing by enhancing safe dressing performance through compensatory dressing techniques and adaptive strategies. This aim is related to the ADL dressing intervention. The clinical reasoning is that Mr. K requires assistance during dressing, so teaching him simplified and safe dressing techniques may allow him to complete more parts of the activity with less caregiver assistance. The second aim is to improve safe functional ambulation by enhancing mobility using an appropriate walking aid. The aim is related to gait training. The clinical reasoning is that improving his gait stability and gait sequencing will allow Mr. K to participate more safely and independently in household mobility while reducing his risk of falls. The third aim is to improve bilateral hand grip strength and functional hand performance to facilitate grasping and object manipulation during ADLs. This aim is related to graded pin strengthening. The clinical reasoning is that increasing hand strength may improve Mr. K's ability to grasp, hold, and manipulate objects required during self-care activities such as dressing, feeding and grooming. The fourth M is to improve Mr. K's safety awareness and reduce his risk of falls through fall prevention education and safe mobility strategies. This is related to patient and caregiver education. The clinical reasoning is that educating Mr. K and his wife about safe mobility, appropriate working aid, use and environmental safety can improve carryover of safe strategies into the home environment. Based on these treatment aims, I selected 3 main interventions during the session, which were graded pinch strengthening, ADL training for dressing, and gait training for ambulate. My first intervention was graded pinch strengthening. The purpose of this intervention was to improve Mr. K's bilateral hand strength and functional hand performance required for activities of daily living. This intervention was used as preparatory activity because improving hand strength can prepare the client for meaningful occupations that require grasping and object manipulation. Mr. K was positioned in a stable sitting position with proper back and foot support. I demonstrated the activity before asking him to perform it. He was provided with graded resistance ranging from yellow, green, blue, red and black. He performed the pinch strengthening activity for both hands, completing 3 rounds for each hand. The resistance was progressed gradually according to his tolerance and ability. During the intervention, I monitored his hand position and movement to minimize compensatory movement and provided rest periods when required. The therapeutic value of this intervention was to improve muscle strength, grip endurance, pinch strength, and functional hand use during ADLs. My second intervention was ADL training for dressing. The purpose was to improve Mr. K's independence in dressing by teaching simplified dressing techniques and compensatory strategies. This is an occupation-based intervention because Mr. K practiced the actual occupation of dressing using real clothing. For upper body dressing, Mr. K was taught to cuff or roll the shirt before dressing. He then inserted his head through the neckline, followed by his arm into the sleeves, and adjusted the shirt into the correct position. For lower body dressing, he was instructed to perform dressing in sitting for safety. He was taught to cuff or roll the pants, lift one leg over the opposite leg to facilitate insertion of the foot and repeat the same technique for the other leg. He then lifted his buttocks one side at a time to pull the pants up and adjust the clothing. The clinical reasoning was that Mr. K had an MBI dressing score of 5 out of 10 and required assistance during dressing. Therefore, compensatory techniques were introduced to reduce the balance demand of dressing and promote greater independence. During the intervention, Mr. K demonstrated good motivation and preferred to perform the activity independently. Verbal cues and physical assistance were provided only when required, while close supervision was maintained for safety. The therapeutic value of this intervention was to improve occupational performance, promote independence, improve motor planning, and increase confidence in self-care. My third intervention was gait training. The purpose was to improve safe functional ambulation using an appropriate walking aid while reducing fall risks. This is considered an occupation-based intervention because functional mobility is part of ADL and is required for safe participation within the home and community. Initially, Mr. K was trained using a standard walking frame. I first demonstrated the correct gait sequence using the 3-point gait. Mr. K was then instructed to advance the walking frame first, followed by the weaker or affected lower limb, and then the stronger lower limb, which is 3-point gait used. He practiced walking along a 10-foot straight pathway for 4 sets, with rest breaks provided according to his tolerance. The clinical reasoning was that Mr. K demonstrated impaired ambulation and high fall risk, as shown by his MBI ambulation score of 3 out of 10 and tenacious score of 11 out of 10. Therefore, gait training was provided to improve gait sequencing, postural stability, and safe use of the walking aid. During the intervention, Mr. K demonstrated good motivation and willingness to participate. However, he continued to require close supervision, verbal cues, and an appropriate walking aid to maintain safety. During the management of this case, several precautions were taken to ensure Mr. K's safety. Firstly, falls needed to be prevented during therapy because Mr. K has a high fall risk. Therefore, he was supervised during all standing and mobility activities. The walking frame was also checked to ensure that it was correctly adjusted before ambulation. These precautions were necessary because Mr. K's initial tenacious score of 11 out of 28, indicating a high risk of falls. Secondly, the therapy environment was kept safe and free from hazards. The treatment area was kept clutter-free with adequate lighting. Loose objects and slippery surfaces were removed where possible. Wheelchair brakes were locked during transfer, and a stable chair with armrest was used during dressing activities. This was important because environmental hazard may further increase Mr. K's risk of falls. Thirdly, Mr. K was monitored for fatigue, dizziness, and reduced concentration throughout the intervention. Adequate rest breaks were provided, and the activity intensity was gradually progressed according to his tolerance. The activity would be stopped if he developed dizziness, chest pain, significant fatigue, or sudden neurological deterioration. This precaution was particularly important because Mr. K is an older adult with a history of recurrent stroke, hypertension, and dyslipidemia. Lastly, communication was modified according to Mr. K's condition. Short and simple instructions were provided, with one instruction given at a time. The activity was demonstrated before asking Mr. K to perform it. An additional processing time was provided. His understanding was confirmed before progressing to the next step. This was necessary because Mr. K demonstrated slurred speech, comprehension difficulties, poor attention, and easy distractibility during the assessment. There was also several situations that needed to be avoided during therapy. Mr. K should not be left unattended during standing, transfer, or ambulation because of his high fall risk. He should not be progressed to unsupported standing or walking unless he demonstrates adequate balance and safe use of the walking aid. Multiple or complex instructions should also be avoided because they may increase confusion and affect his task performance. Finally, therapy should not be continued if Mr. K demonstrates excessive fatigue, dizziness, significant pain, or sudden neurological deterioration. Assessment reporting B2. Next, I will explain the assessment results and their functional significance. The modified Bartle Index was conducted to assess Mr. K's overall independence in basic ADLs, determine the amount of assistance required, identify difficulties in dressing and mobility, and determine the areas requiring occupational therapy intervention. Mr. K obtained a total score of 65 out of 100, indicating moderate independence in ADLs. He scored 4 out of 5 for personal hygiene, 3 out of 5 for bedding, 8 out of 5 for feeding, 5 out of 10 for toilet use, 5 out of 10 for dressing, 5 out of 10 for stair climbing, 10 out of 10 for bowel control and bladder control, 12 out of 15 for chair or bed transfer, and 3 out of 10 for ambulation. Overall, Mr. K demonstrated relatively better independence in feeding, bowel, bladder and control and transfer. However, he continued to require assistance or supervision in bedding, dressing, toileting, stair climbing and ambulation. His main functional limitations were related to balance, mobility and upper limb function. The second assessment is the numeric rating scale was conducted to assess Mr. K's perceived pain intensity and compare his pain before and after intervention. He reported 0 out of 10 before intervention and 3 out of 10 after intervention. However, this result should be interpreted with caution because Mr. K demonstrated difficulty understanding the NRS due to his communication and comprehension difficulties. Third assessment, the Montreal Cognitive Assessment was attempted to screen Mr. K's cognitive functioning following his recurrent stroke. However, he was unable to complete the assessment because he had difficulty comprehending the instructions. He also demonstrated poor attention, poor concentration, easy distractibility and slurred speech. Therefore, no valid score was obtained and the result was considered invalid. I would recommend an alternative cognitive screening assessment such as the MMSE or SLUMS when Mr. K is able to understand the assessment instructions sufficiently. Third assessment is manual muscle testing. For manual muscle testing, the purpose was to assess Mr. K's upper limbs muscle strength and identify weakness that may affect reaching, positioning and ADL performance. The right upper limb demonstrated relatively normal strength, which is 5 out of 5. For the left upper limb, shoulder flexion was 4 minus out of 5. Shoulder extension was 4 plus out of 5. Elbow flexion was 4 minus out of 5. Elbow extension was 4 plus out of 5. Wrist flexion was 4 out of 5 and wrist extension was 4 out of 5. This finding indicated mild weakness in the left upper limb, particularly during shoulder and elbow flexion. This weakness may affect reaching and manipulating offloading during dressing. The JAMA dynamometer was conducted to objectively measure Mr. K's bilateral grip strength and determine whether hand weakness may affect functional grasp. His right hand measured 14.7 kg force compared with the stated normative value of 34.2 kg force. His left hand measured 20 kg force compared with the stated normative value of 29.4 kg force. Therefore, both hands demonstrated reduced grip strength compared with the stated normative values. This may affect his ability to generate sufficient grip force and manipulate objects during functional activities such as dressing and other self-care activities. And then Tineti Balance and Gait Assessment. The Tineti Balance and Gait Assessment was conducted to assess Mr. K's balance, gait performance and fall risk. Initially, he obtained a total score of 11 out of 28, consisting of a balance score of 6 out of 16 and gait score of 5 out of 12. This indicates impaired balance, impaired gait performance, and a high risk of falls. During the assessment, Mr. K demonstrated hesitant and discontinuous gait, frequent stopping during turning, marked transfer, and reduced gait stability. Therefore, the assessment findings supported the need for gait training, balance intervention, and fall prevention strategies. Based on the assessment findings and identified occupational performance problems, I selected 3 main interventions for Mr. K. Interventions were graded pin strengthening, ADL training for dressing, and gait training. These interventions were selected based on his reduced bilateral grip strength, difficulty in dressing, impaired functional ambulation, and high risk of falls. The first intervention provided was graded pin strengthening. The aim of this intervention was to improve Mr. K's bilateral hand strength and functional hand performance, particularly for activities that require grasping and manipulating objects during daily activities. This intervention was classified as a preparatory activity because the main focus was to improve the physical capacity of the hands before applying the improved strength to functional activities. For the technique, Mr. K was positioned comfortably in sitting with proper support. The therapist first demonstrated the activity and provided simple instruction before allowing Mr. K to perform it independently. Mr. K was provided with graded resistance using yellow, red, green, blue, and black resistant materials. He was performed pinch strengthening using both hands, with 3 rounds for each hand. The resistance was progressed gradually according to his ability and tolerance. During the activity, the therapist monitored Mr. K's hand positioning and movement to ensure that he was performing the activity correctly. Verbal cues were provided when required, and adequate rest periods were given to prevent excessive fatigue. The activity was performed for approximately 15 minutes, with the frequency and repetition adjusted according to Mr. K's tolerance. For the home program, Mr. K was encouraged to continue simple hand strengthening activities at home using safe and appropriate resistance. His wife was also educated to supervise the activity when necessary. The precautions were to avoid excessive resistance, prevent over-fatigue, and stop the activity if Mr. K experienced pain, discomfort, or unusual symptoms. The clinical reasoning for this intervention was based on Mr. K reduced bilateral grip strength, with the right hand measuring and improving hand strength may support his ability to grasp and manipulate objects during ADL, particularly dressing. The second intervention was ADL training, focusing on dressing. The aim of this intervention was to improve Mr. K's independence and safety during dressing by teaching him appropriate compensatory and energy conservation techniques. This was an occupation-based intervention because Mr. K practiced the actual dressing activity using his own clothing. Before starting the activity, I demonstrate each dressing technique and provided one instruction at a time to ensure that Mr. K could understand and follow the sequence. For upper body dressing, Mr. K was instructed to cuff or roll the shirt before putting it on. He was then instructed to insert his head through the neckline, followed by the arms into the sleeve, and finally adjust the shirt into the correct position. For lower body dressing, Mr. K was instructed to perform the activity in a sitting position to improve safety and reduce the risk of losing balance. He was taught to cuff off roll the pants and use the leg crossing technique to facilitate insertion of the foot into the pants. The same technique was repeated for the opposite leg. After inserting both legs, Mr. K was instructed to lift his buttocks one side at a time to pull the pants up and adjust them into position. I provided the verbal cues and minimal physical assistance only when required, while encouraging Mr. K to complete as much of the activity as possible independently. The activity was performed for approximately 20 minutes, depending on Mr. K's tolerance and performance. For the home program, Mr. K was encouraged to practice the dressing techniques during his daily dressing routine. His wife was educated to provide supervision and assistance only when necessary, rather than completing the whole task for him. The precautions were to perform dressing in sitting, avoid rushing, maintain a stable position, and provide close supervision because of Mr. K's impaired balance and high fall risk. The third intervention was gait training. The aim of this intervention was to improve Mr. K's functional ambulation, gait sequencing and safety during mobility while reducing his risk of falls. This intervention was classified as a purposeful activity because walking is directly related to Mr. K's functional mobility and is required for participation in daily activities. Before starting, the therapist ensured that Mr. K was wearing appropriate footwear and that the walking area was clear of obstacles. The walking aid was also checked to ensure that it was safe and appropriately positioned. Mr. K was trained using a standard walking frame. The therapist first demonstrated the correct 3-point gait sequence. Mr. K was instructed to first advance the walking frame forward, followed by the weaker lower limb and then the stronger lower limb. The therapist provided short and simple verbal instruction and allowed additional processing time before progressing to the next step. Mr. K practiced walking along a 10-foot straight pathway for 4 sets. Rest periods were provided between sets according to his tolerance. During gait training, the therapist maintained close supervision and provide verbal cues to improve gait sequencing, foot placement and safety. For the home program, Mr. K and his wife were educated regarding the safe use of the walking frame. His wife was advised to provide close supervision during walking and to avoid allowing him to walk independently in situations where he may be at increased risk of falling. The precautions were to avoid walking without appropriate supervision, ensure the walking aids was positioned correctly, maintain a clear pathway and stop the activity if Mr. K experienced dizziness, excessive fatigue, pain or sudden change in his condition. Overall, Mr. K demonstrated good participation and motivation throughout all intervention activities. He preferred to perform activities independently and consistently attempted to complete the task when instructed. That concludes my case presentation. So, thank you, Madam Hidayah.